9 out of 10 people who come to me ask me about Retatrutide are asking me the wrong question. I'm not going to tell you not to be interested in it. The data is real. I'll show you the numbers myself. But here's the thing. I'm Dr. Lee. I prescribe these every single day. The GLP-1s, Semaglutide and Tirzepatide. And I'm on Terzepatide myself. They're here. They're available right now. I know what they do. I know who actually needs to switch and who doesn't. So before I'd ever talk to a patient about switching them to Retatrutide or jumping to any new shot, there are 3 questions I ask first. And most people can't get past the first one. The third one is where almost every one of you actually lives. Stay with me for that. Here's what I know that the internet won't tell you. These medicines work, and I don't mean sometimes. Picture 10 people who start one of these shots. 9 of them lose real weight. 9 out of 10. That last person, the one the shot truly does nothing for, is rare. You could line up 10 people and barely find them. So when your scale stops and the first thing you think, it's not working for me, the odds say you're almost certainly wrong about that. It is working. Something else is getting in the way. And here's the part nobody wants to hear. A stronger shot does not move whatever that something else is. That's what these 3 questions are really about. So question 1, did you actually give the drug you're on a fair shot? And I mean actually. Here's what I hear constantly in my clinic every week. Doc, Semaglutide isn't working. I want something stronger. And then I look at the chart. 8 weeks in, still under starting dose, never titrated up, and honestly not even taking it on the same day each week. That's not a failed medication, that's an unfinished one. And this is the part I can't say loudly enough because it's the fix for more of you than anything else. Pick your shot day and keep it. Same day, every 7 days. Put it on the calendar, set the alarm, treat it like it's not optional because it isn't. The people who tell me it stopped working are so often the people who drifted. A shot on Monday, then the next one Thursday, then they skipped a week on vacation and never really got back on track. Your body needs a steady level. Give it a consistent 7-day rhythm before you decide anything. Now let's talk about those big Retatrutide numbers. In plain English, because the way they get thrown around is built to make you feel behind. Forget percentages for a second. Let's use a real person. Say you start at 50 pounds. On Semaglutide, the average person drops about 40 pounds. On Tirzepatide, about 50. And Retatrutide, the big new one everybody's chasing, about 70. 70 pounds. That's real. I'm not going to pretend it isn't impressive, but watch what that number does inside your head. You see 70, you look at your 50, and suddenly you feel like you're missing out. So let me do the math nobody does for you. The jump from Tirzepatide to Retatrutide is maybe 20 pounds. But most of you asking me about Retatrutide haven't even gotten what Tirzepatide already gives you. You still got 30, 40 pounds sitting right there on the drug in your fridge. And you're reaching past it to grab an extra 20 you haven't earned yet. It's like trading in your car for a faster one when you never once put gas in the one you already own. And real quick, if this is already clearing things up for you, do me one favor, hit subscribe. I put one of these out every single week. All right, back to it. Now, before I say this next part, let me be really clear. There is nothing wrong with Semaglutide. It's an excellent medication. It's more affordable than Tirzepatide, and I have patients who absolutely killed it on Semaglutide, did exceptionally well, hit their goal, never needed to switch a single thing. So this is not me telling you Tirzepatide is better. Everyone is different. The next part is only for the specific person who generally gave Semaglutide a fair, full run, and it still isn't doing the job. If that's you, this is the most concrete next step I can give you in this whole video. Here's the test. You've titrated up, you're on a solid dose, you gave it real time. Ask yourself 2 things. Did it actually quiet the food noise? And do you feel genuinely full? That slowed down, satisfied fullness after a normal sized meal? Because that fullness is the delayed stomach emptying these drugs are supposed to give you. If the answer is no, if you maxed it out and the food noise is still loud and you're still hungry, that's not your signal to sit around waiting for Retatrutide. That is your signal that the next rung is Tirzepatide, Zepbound, Mounjaro. And I'm telling you, this as someone who's taken both. I take Tirzepatide myself, I responded to both, but Tirzepatide is the one that worked best for me. It's what I'm on. And I've watched patient after patient who felt almost nothing on Semaglutide come alive on Tirzepatide. So before Retatrutide is even a conversation, if Semaglutide isn't doing it, the next move is Tirzepatide, not the drug that isn't even approved yet. That's a conversation to have with whoever prescribes for you. And once you're on Tirzepatide, you run the same playbook. You don't just coast. You titrate up appropriately with your provider while you actually check the boxes, protein intake, cardio and weights for the calorie deficit, and you step the dose up accordingly as you go. That is a fully run Tirzepatide protocol. Most people asking me about Retatrutide have never once actually gotten there. So that's question one. And honestly, most of you could stop right here, get consistent, finish the drug you've already got, and never think about Retatrutide again. But I can hear some of you already, no doc, I really did all of that and it still didn't work. If that's you, that's question two, and it's a completely different conversation. Question two, are you truly a non-responder? Because true non-response is real. I told you you're in 1 in 10, but that person exists. And if it's you, I'm not going to abandon you with a shrug. Here's how I define it. Full therapeutic dose, on it long enough to count, actually taking it on your day every week, and still under 5% at 12 weeks. All 4 have to be true, and when I sit down and go through them with a patient, most of the time, one of them isn't. But if all 4 are true, if you really did everything right and the scale won't move, then you and I take a different path. And I want you to hear what that path actually is, because it is not just a grab a stronger shot. It's sitting down and dealing with the side effects that are making you miss doses. It's the lifestyle pieces nobody wants to hear. The calorie deficit, which is still the bottom line, no matter which shot you're on. It's your mindset, because this is a long game, and the people who win are the ones who stay on it. It's moving your body, protecting your muscles, and it's commitment. The steady weekly rhythm again, month after month. That is the work that actually moves a true non-responder, not a new molecule. The molecule was almost never the thing standing in your way. Now, I'll be fair, if you genuinely did all of that, there is a real mechanism argument for Retatrutide. Semaglutide hits 1 receptor. Tirzepatide hits 2 receptors. Retatrutide adds a 3rd glucagon receptor. And that 3rd lever pushes energy expenditure and hits liver fat in a way that others don't. For a real non-responder, try a mechanism you haven't tested yet is a legitimate thought. I'll give it that. It's just that almost nobody asking me is that person. Which brings me to question 3, the one I promised you at the very start. Because if you're not a true non-responder, and you're probably not, then this is where you actually are. Question 3, are you just stalled? And this right here is where almost every single one of you are right now. So I need you to really hear this part. Stall is not a failure. A stall is your physiology doing exactly what it's supposed to do. You've lost weight, you're a smaller person now, and think about it like this. Your body is like a smaller car now. A smaller car doesn't need as much gas just to run. So you burn less than you used to, even doing nothing. And that, up with the muscle you lost on the way down, and at some point, what you eat and what you burn land in the same spot. The scale stops. The drug didn't quit on you. The mass just evened out. And here's the trap. The whole reason I made this video, a new molecule does not fix a stall. It papers over 1, you'll switch, you'll get 8 to 12 good weeks off the novelty, and then you'll stall again. Except now, you're on a stronger drug with fewer places left to go. You spent your last card to buy 3 months. What actually breaks a stall is the unglamorous stuff. Protein up, a gram per pound of goal weight, and most of you are at half that. Resistance training, twice a week minimum. Sleep, and an honest, written, 7-day look at what's really going on in your mouth. Because intake creep is real, and it's invisible from the inside. Do that for 8 weeks before you go looking for a new molecule. I've watched it restart more stalls than any dose increase I have ever ridden. So, those are your 3 questions. Answer them honestly, and your next move is already sitting right in front of you. But I know some of you are still going to be tempted to chase Retatrutide anyway. So before you do, let me hand you 2 things about it that nobody else is telling you. And I want to be completely straight with you about where this drug actually stands. Retatrutide is not FDA approved, period. Right now, it only exists in 2 places. 1, in research, in the clinical trials in the labs where it is still being studied. 2, on the gray market, vials sold online. That's it. Those are the only 2. The approved version doesn't exist yet. Lilly just said they're filing early next year. So realistically, you're looking at 2028. As for those gray market vials, I don't recommend them flat out. When you buy one, you generally have no idea what's really going on in that bottle. So stick with what's actually here. The approved drugs that work, that can get you today with a doctor actually watching over you. And in that same big trial, at the highest dose, about 1 in 8 people got something with a fancy name, dysesthesia. Here's what that word means in plain English. Your skin starts burning, tingling, pins and needles for no reason at all. 1 in 8 sit 8 people down at a table, and one of them now feels like their skin is buzzing. And about 1 in 9 quit the drug completely. The side effects just weren't worth it. More weight loss is never free. It has never been. So 3 questions. Did you actually give the drug you're on a fair, consistent shot, and you truly not responding? And if so, are you doing the real work that moves that? Or are you just stalled, looking for a molecule to fix something that isn't about the molecule? Answer those honestly, and the next move is usually already sitting right in front of you. Now, here's how I can actually help you do this. Because doing this alone, guessing at your dose, guessing at your food, that's the hard way. If you want it done right, the shot day rhythm, the protein, the dose titration, someone in your corner. That's exactly what my membership program is built for. So go to the link in my description. Everything's there. More information, how to get started, and a free guide that lays out the exact stall breaking protocol I just walked you through, step by step, yours to keep. It'll show you your safest next step. Or comment GLP1 on any of my posts on Instagram at GLP1 Dr. Lee, and I'll send you the information myself. And do me a favor, tell me in the comments, how long have you been stalled and what are you on? I read these and I answer what I can. Then hit subscribe. I put out a new one every week. I'm Dr. Lee. I'll see you in the next one.